Hi there, my name is Dr. Raj Chovatia. I'm a clinician scientist and dermatologist based out of Chicago, Illinois in the USA. So, thinking about our subsets of patients based on race and what immune phenotype looks like is kind of where the rubber meets the road. We have a few studies that are potentially suggestive, but they all have certain flaws in them, right? Most of them are convenient samples based on patients who have been identified in a single center. Most of them are going to be people who actually be willing to be recruited in said study, and they probably don't speak for the heterogeneity of a particular racial group across an entire country or world, let's say, meaning that there's a variety of environmental factors that may be at play. So even though there is very small sets of data that suggest that there might be key immunophenotypic differences, as we've kind of moved away from race-based medicine and a lot of other specialties, I would suspect that this changes in dermatology as well. So I think that the way that I might think about this is that there are going to be patients probably across all sorts of groups based on a variety of other extrinsic and intrinsic drivers that just may have broader immune phenotypes. And even for people that may have sort of more narrow activation of type 2 inflammatory mechanisms, JAK inhibition is quite attractive and intriguing just given the fact that every single patient has multiple cytokines and multiple pathways of activation. Whether somebody has 3 key signals, 5, 7, 9 others, they all sort of feed into the same pathway. And so while I won't sit here and say that every patient is a JAK inhibitor patient, JAK inhibition as a therapeutic strategy, both in atopic dermatitis and broadly in chronic inflammatory disease, is highly rational just based on the inherent heterogeneity that exists in disease itself.